Greetings everyone, my name is Dr. Supratik Bhattacharyya. I'm a consultant endocrinologist based at Kolkata. And today I am going to talk about the rationale of the combination of SGLT2 inhibitor with a DPP4 inhibitor. And in particular, we are talking about the fixed dose combination of empagliflozin and linagliptin. We are also aware from the studies done by Dr. Kunti et al. That unless we intensify the treatment and bring down the HbA1c to the target level within the first year of diagnosis, the chances of CV disorders are significantly increased at the end of 5 years. So we need to sort of intensify the treatment right from the beginning. And if we see that the entry HbA1c is high, for example, it's more than 8.5, we're absolutely justified in sort of starting on more than one treatment for the diabetes from the very beginning. So along with metformin, we're absolutely okay to start with a combination of empagliflozin and linagliptin, for example. So if you combine a SGLT2 inhibitor with a DPP4 inhibitor, not only you'll get a very robust reduction in the HbA1c, and we'll get to the HbA1c target very fast, but at the same time, it's a very rational combination because both are absolutely known not to cause any hypoglycemia at all. In fact, in overweight or obese candidates, we know that SGLT2 inhibitors causes a robust amount of weight loss, which is beneficial in the long term. Again, we know that SGLT2 inhibitors work very well when the HbA1c is more than 8.5, and DPP4 inhibitors work very well when the HbA1c target is less than 8.5. So if we combine both, we are ensured of covering the entire spectrum and getting to the target very, very fast. Moreover, we have multiple pleiotropic benefits of using this combination. For example, SGLT2 inhibitors are known to cause a robust decrease in the blood pressure as well. So systolic to the tune of around 4 millimeter mercury and diastolic to the tune of around 2 millimeter mercury. It also has a uricosturic effect, and for those who are suffering from hyperuricemia, this would be very beneficial. SGLT2 inhibitors in particular are now coming into focus as a part of treatment for NAFLD or NASH, and we know that fatty liver is something that the patients present with when they come with diabetes and when they're overweight or obese, and because of the insulin resistance that they have. Linagliptin, again, is very unique because of its structure, it also has a xanthine oxidase kind of a property, and which is beneficial in case of hyperuricemia as well. With the incoming data from the empagliflozin studies like the EMPERAGE and also the EMPEROR reduced, which in particular talks about the effectiveness of empagliflozin in HFrEF patients or patients with reduced ejection fraction. We know that empagliflozin does have a role in prevention of heart failure and also reduction in hospitalization due to heart failure patients. So, we know that SGLT2 inhibitors as a class is safe for the kidneys, and it's also beneficial for the kidneys. So if you consider the renal composite as such, we see that it's beneficial for the kidneys. And we also know that whether it's progression of the CKD or reversal of microalbuminuria, SGLT2 inhibitor does a wonderful job. Again, one big advantage of the combination of SGLT2 inhibitor plus DPP4 inhibitor is that we had seen that empalina in particular, if you introduce as a fixed dose combination, has got much lesser chances of urinary tract infection or genital mycotic fungal infections as compared to when SGLT2 inhibitor like empagliflozin is given alone. So we are actually getting a much robust decrease in the HbA1c and also reducing the adverse effects which are known to occur very commonly with the SGLT2 inhibitors. And I would like to share one of the real-world study that me and Dr. Manisha Khalse had done, and it was published in the International Journal of Diabetes very recently in May. And the title was Clinical Effectiveness of Empagliflozin and Linagliptin Combination in Overweight and Obese Type 2 Diabetic Patients and Indian Real-World Experience. So in this, what had happened was we were looking retrospectively into the electronic database of around 250 type 2 diabetic patients who were previously uncontrolled on metformin alone, up to a dose of around 1.5 grams, and they all had a BMI of more than 25, 6 months. And what we saw, when you look at the glycemic parameters, the HbA1c at baseline was around 9.4. It came down to around 7.4 by the time it was 3 months, and it came down to 6.7, which was a drop of around 2.7% at the end of 6 months. When you look at the fasting, at baseline it was around 154. By the time it was 3 months, it came down to 128, and by the time it was 6 months, at the end of the study, the fasting dropped by around 42 milligrams. If you look at the prandials, the baseline prandials was around 260. It came down to around 184 by the time it was 3 months, and at the end of the study, at the end of 6 months, it had dropped down to 145 mg, and that was a drop of almost 115.8 milligrams. Another very interesting finding was that if you looked at the body weight, the mean body weight to begin with was around 79.4 kg. At the end of the study, it was around 71.2 kg. And most of the body weight was lost within the first 3 months. So if you look at the 3-month data, the patient had almost lost around 4.8 kg. And by the time it was almost 6 months, they had lost around 8.2 kg. Again, the BMI dropped by almost 3.3 at the end of the 6-month study. The waist hip circumference also came down significantly. The mean systolic blood pressure dropped by around 4.7 millimeter mercury, and the mean diastolic dropped by around 1.5 millimeter mercury, which is coherent and sort of in tune with what we usually expect with the SGLT2 inhibitors. So in order to conclude, what we wanted to say was that a fixed dose combination of EMPA and LINA appears to be an effective treatment choice in type 2 diabetic patients with high BMI and uncontrolled on metformin monotherapy over 24 weeks follow-up duration. And we did notice additional pleiotropic benefits in terms of lowering of systolic blood pressure, reduction in the body fat parameters, and also I think it's a very rational combination for the physician. And if anyone has a high N3 HbA1c, they need to consider beyond metformin to use a combination, a rational combination like EMPA-LINA from the very beginning in order to achieve the target HbA1c and the other goals very soon.